Can you guys kind of see this whiteboard here? Don't worry if some of the words, some of that's my notes to myself to remind myself to talk about them. That's why they look terrible right now. Don't worry about that yet. Okay, so what we're doing here is we're going to learn about these two bones today. Scapula and the humerus. Literally, my brachial bone and my scapula, my shoulder blade. We're going to learn about them, and we're going to spend a lot of time talking about, like, what's this ridge called? What's that thing called? What's this thing called? What's that little divot there called? What's this called? What's this bump next to it? What's the space between these two bumps called? Because we will later find out that muscles attach to all this stuff. But before we go there, that's very dry material. It's very important, but it's dry material. I want to talk to you about how the scapula moves around a little bit, so that these are muscles that we are later going to find out attach to these bones to move them around, right? Now, muscles can only do one thing. What is that one thing?
Contract and tighten.
Contract and shorten, right? They can only pull. So these are muscles that can pull on the scapula or the humerus and cause them to go places. So first, I want to talk to you. And by the way, we are going to have days in this class where we discuss these muscles directly. So as much as it terrifies me as a teacher to say this, if you were to miss some of this material, we're going to go over it again because we are going to have classes on these muscles. Today's class is really on the bones. You learn all the parts of the bones, and later you learn about muscles that attach to them, what they do. But I wanted to give you a preview of where we're headed to help you to compartmentalize this material and know what files to drop it into and just kind of see big picture, okay? But don't be worried, we are going to talk about these muscles again specifically. So, you've got, I hope I'm right too, I got to think off the top of my head. You've got 5 muscles that attach to the scapula and move it around your rib cage. So remember, my scapula is back here, and my scapula can go out, in, up, down, and twist, right? Those are the 6 things it can do, right? When it goes up, what do we call that? Somebody? Anybody?
Elevation.
Elevation. When it goes down, what do we call that?
Depression.
Depression. When it goes out and around here, what do we call that?
Isn't it adduction? Is it adduction?
AB.
Abduction. It's getting further away. Adduction is when it's going back, right? It's adding back.
I'm sorry.
Yeah, don't be sorry. You're answering and I'm happy. Participation is what makes me happy. But anyway, adduction. Cool. And then if I lift my arm out to the side, it actually starts to rotate like this. And what do we call it when it rotates like that?
Superior
rotation.
I love the superior, actually. Upward rotation.
Oh.
You could probably say superior rotation. People would be like, oh. So superior rotation, when my arm comes back down, it's inferior rotation. Now you got me saying it. It's downward rotation. I'm stuck now. It's in my head. Anyway, superior rotation is excellent. But anyway, upward rotation, downward rotation, or superior rotation and inferior rotation would easily work. So those are the 6 movements, and we get those from these 5 muscles. And how do we do that? I'm going to kind of show you here and then on the skeleton and such, because it's really, really interesting. And here's the part that's hard to explain, but so cool about scapulas. Oh my God. So the scapula is carrying another joint with it. It's kind of like the base of a crane, and the crane can drive around. So you've got an arm that's a ball and socket and does all this cool stuff. Right? This is your glenohumeral joint. I'll explain why later, but this is your shoulder joint. It does all this neat stuff all by itself, but the scapula travels along to take it to places before it unloads this crane, which is why you have so much movement, because you actually have 2 joints. You've got this joint that can go abduct and adduct, elevate, depress, upward rotate, downward rotate, and then at the end of it, after it's gotten to wherever it's going, this thing can deploy and flex, extend, abduct, or adduct, and rotate too. So, sorry, it's actually quite cool. Anyway, so hold on. I saw a hand go up. Somebody? Well, I heard a hand go up. Please.
It's me, Suriel.
Oh, yes. Sorry. Ms. Suriel, please.
I just got a quick question. So, what makes the scapula to move? Is it muscles or is it attached to another bone besides the arm?
No, it's muscles.
Oh, okay.
It's muscles.
Okay, thank you.
Very much so. It's muscles that essentially allow it to glide along the rib cage. And your rib cage, it's very hard to see this, but your rib cage is just an egg of ribs. And you don't look like an egg because your shoulders square you off. You do not look like an egg because your shoulders square you off. But my rib cage comes up like this. My rib cage, I'm a nice egg. If you look at this guy and we took off the shoulders, the rib cage is just an egg up here. And this scapula moves around it. This is what squares off our lovely thing. It's the collarbone here attached to the scapula, all that kind of stuff. But this is just an egg. Really, very much egg-like. Boom. Okay? So, the scapula gets pulled around that egg. And let's talk about how it does that. Okay. So, you've got 5 muscles that attach to the scapula and move it around. One is your trapezius. And when I discuss the trapezius, I like to partner it with the levator scapula and the rhomboids, and I'll explain why. But they tend to sometimes work together, just like you have lab partners. Doesn't mean you're always with them, but sometimes you are. And if I was looking for one of you, I might look for the other one, that kind of thing, right? And sometimes you're doing the same stuff. So the lab partners for the trapezius are the levator scapula and the rhomboids major and minor. And again, I promise you we have an entire day on trapezius, an entire day on rhomboids major and minor, an entire day on levator scapula. This is actually a bone day, but I just thought for some of you it's good to have big picture. So, your trapezius, very simply put, is this diamond-shaped muscle that goes kind of from the back of your head to your to your scapula and your spine. Looks like a kite on your back. We think of the trapezius as just up here, but it actually is a kite up there. It really is. Now, strangely enough, it's actually got 3 parts to trapezius. And this is what's kind of interesting about it. It's got an upper part here, right? You kind of see it going up at an angle. Well, if you had ropes going here and attached from my head to my shoulders, and you shortened those ropes. This is ridiculous. I don't know why I do it. I'm embarrassed to admit it, but to this day, I imagine tiny little elves holding ropes on these origins and insertions and pulling them to figure out actions. It's worked for me forever. Feel free. I've got extra elves if you need them. But anyway, if I put an elf up here and an elf down here and they both started pulling a rope, what do you suppose would happen? I don't know, Tapscott.
The elevation of the scapula?
Elevation of the scapula. Because the upper trapezius grabs onto this and pulls it up. Pulls it up in diagonal a little bit, but it pulls it up, elevates the scapula. Hey, you've got fibers down here that run down. They run down. If I hooked ropes to the scapula and ran them down and pulled on them, what do you suppose would happen?
That'd be. I can't think of the other word.
I'm worried if you don't get it. I'm worried if you don't get it, you're going to get depressed. I really am.
Oh, no, you made me forget.
Is it depression?
Depression, yes. Elevation, depression. They literally pull the scapula up, they literally pull it down. Up, the upper traps pull my scapula up, my lower traps can pull it down. Again, we're going to study traps later, everybody. But I want you to kind of see what's going on here and why we're learning what we're learning. Yes, Miss Walker, why?
I was just gonna ask if you could move your head so I can see the diagram.
Oh my gosh, yes.
Thank you.
She's like, you get out of the picture. So, I also want you to realize there's middle traps here running across like that, right? So there's one's going up, one's going down, there's one's going across. Let me get my head, okay. One's going across there. What do you suppose that might do, huh? Huh? Somebody, come on.
Was it like?
What? Who? What? Miss Trotter, go for it.
Is it like adducting or adducting? Like
It is adducting. What am I doing right now? Besides looking intimidating. I'm adducting my scapula. My traps are actually pulling my scapula back. Yeah, adducting my scapula. So, back here along with this trapezius, there's a weird little muscle right here called the levator scapula. Anybody want to guess what this muscle running up and down, kind of like the upper traps, called the levator scapula does? Just wild guess. Just throw something crazy out there.
Elevates the scapula?
Elevates the scapula, yes. So the levator scapula kind of works with the upper traps, in general. Not always, but in general. And they both elevate the scapula. The rhomboids are kind of in the middle here, underneath the traps, but in the middle. So what do you suppose they do? Huh? Huh?
Reacts the scapula.
Yeah, they retract the scapula or adduct the scapula. Yeah, well said. So that's why I tend to put the trapezius, levator scapula, and the rhomboids together.
Wait, I got my pins. What did I miss with the rhomboids?
Everything.
No.
The rhomboids run between your scapula and your spine in the middle there, and so they act very much like the middle traps. That makes sense. You just, oh no, I thought you froze, but maybe not.
What's the action that they do? The rhomboid.
Adduction.
Oh, okay, adduction. Okay.
Yeah, of the scapula. Yes, Miss Trotter.
Is there an additional muscle that helps like depression of the scapula as well? Is there like a second one for that one, or
No.
Oh.
I mean, it's not on the back. Not yet. Yeah, but no. There are all sorts of technical arguments that, but no, not in the way you mean. Not like the back thing where the rhomboids are doing what the middle traps doing, the levator scapula is doing what the upper traps doing. No, just not. By the way, just a little side note, a little helpful little hint. If I want to get the skeleton over to me and I'm a muscle, I have to be where I want the skeleton to go, right? I can only pull. So if I want to get the skeleton to go over there, this muscle here cannot do it. I'm about to make a point with this. I have to be over here, right? So muscles in back tend to pull back. Muscles in front tend to pull front because muscles pull. That's all they do. So muscles in front tend to create flexions. Muscles in back tend to create extensions. Muscles on the side tend to create abductions. But my point is muscles have to be at the place that they're pulling to. So we just looked at all these muscles in back, and yes, some lift up or, because they're hooked up in back, but a lot of them are doing this kind of pulling back kind of stuff because they're in back. That's their job. So if we flip the body around and look at the front, there are two important muscles in the front that are hooked to your scapula as well. So this is the front of the chest. Right back here is where we have the trapezius, the rhomboids, levator scapula, boom. If we turn around, we've got two muscles that come out the front that are hooked to the scapula too. We won't get into gore detail how they're hooked to the scapula yet, but just trust me, they are. One is the pec minor. Everybody take your hand like this, like you're in a gang, put it right here, and say pec minor. Yes, it's very important. This is all very important later. Pec minor. Blood in, blood out. All right. So, that's the pec minor and the serratus anterior. Serratus anterior looks like finger-like projections underneath the arm here. Sometimes you see them on bodybuilders. I'm not talking about their lats. Their lats are there, and yes, their obliques are down here too. They've got these like finger-like things going across their stomach. But sneaking out from behind their lats are sometimes these like finger-like projections. I'd show you mine, but it's just not proper to take my shirt off right now. But they're ripped. And if you flex right there, you'll see them, and those are the serratus anterior sneaking out. Well, this stuff is in front, so what do you suppose it does? What do you suppose it does to the scapula?
Abducts.
It abducts the scapula away from the spine, yes, or protracts it, yep. And by the way, to answer Ms. Trotter's question, some of these muscles run slightly downhill, so to speak, slightly diagonal, so you could argue that they help with the depression of the scapula from the front side too. Yep. So I've got muscles in the front of my body competing to pull my scapula forward. I've got ones in back competing to pull it back. I've got ones in back that help lift it up or pull it down. That's good. And to be very honest with you, if you get these muscles to work in certain combinations, you can get a rotation. Because you can ask the upper trapezius, your brain does all this, but it can ask the upper trapezius to pull just this part while releasing the lower part and allowing it to twist, right? So the point is that's how we get all those movements out of the scapula. Those 5 muscles get all the movements out of the scapula. And I would say that trapezius, levator scapula, rhomboids, major and minor, which look like the same muscle, are stacked right on top of each other. Pec minor and serratus anterior are super duper important muscles. They will laugh at you as a massage therapist if you don't know what they are. And we will study them, don't get me wrong. I just want to let you know, these are not minor things. These are major, major muscles. Major muscles that some massage therapists can't find. Many massage therapists can't find some of them. You guys will all be able to by the time we're done, don't worry. Anyway, trapezius, levator scapula, rhomboids, major and minor, pectoralis minor and serratus anterior. And these muscles grab onto places onto this scapula and fight over it and move it around. And they literally do fight over it sometimes, which will kind of give us some clues on how to be better shoulder rubbers too. So that's that. That moves the scapula and gets it into position to where it's ready to deploy the crane, the arm of the crane, right? And that's very helpful. That's why I can grab stuff over here. My scapula can bring it up over here, right? And I can twist way up here. I can get all the way up here and all the way down here behind my back and all sorts of stuff, all right? So, so there has to be muscles then that tie this bone to the scapula so that it can move around, right? And again, you don't have to absorb all this, but I just want to give you an overview. There are 4 rotator cuff muscles. You guys have probably heard of rotator cuff muscles before. People are always like, I tore my rotator cuff. Rotator cuff muscles that help to move this arm around. They're very tiny and they're actually on the scapula. And you actually will rub the scapula on your clients to work these muscles. But anyway, those are rotator cuff muscles. If you're interested, there's a supraspinatus, infraspinatus, teres minor, and subscapularis. Those are the 4 rotator cuff muscles. Then you have your deltoids over the top of them. That's these suckers right here. They're over the top of those, your deltoids. And those are kind of some of the main movers of your arm. But you've got more. Your latissimus dorsi, which is your lats, the big V thing that you see in the back, that hooks on to your humerus and it helps you pull it down and things like that. And your pectoralis major hooks over your arm and allows you to do things like bench press and push-ups and things like that. You've also got some other cute little muscles like a coracobrachialis that we haven't even gotten to yet. Cool. So, all of those muscles attached to the bumps we're going to be learning about now. And that's important. And at the end of all this, you'll be able to actually understand how a human being does this, or possibly why they can't do it. So to give you an example, when somebody comes into me and says, I'm having a hard time moving my shoulder, I recognize that they really have two shoulders. They've got a scapulothoracic joint, which is how their scapula moves around their body, and they've got a glenohumeral joint, which is this ball and socket in here. And so I look at how they're compensating, because a lot of people are like, I can't raise my arm up all the way. Well, if their scapula is kind of how they lift up their arm like this, my scapula is working just fine. They're able to get their scapula up to where it needs to be all the way up here. So their scapula functions fine right here, their glenohumeral joint is not. Or you'll see some people who are like, I can't get my arm above here. Oh, well, you can't get your arm above here because that's as high as this joint goes, but this joint's working then. Your scapula's not working. You're not able to upwardly rotate it. Maybe you've got a problem in your levator scapula or your upper trapezius. So you're able to start to do that kind of problem solving. And that's just the tip of the iceberg. I told you it was going to be a good day. I told you. I tried to warn you. Okay. All right, let me share my slideshow with you. We'll talk about these bones. Oh, last thing too, word of caution, by the way. If you don't learn all the little bumps on the bones, everything else becomes extremely difficult. Because then you don't really know what stuff is attaching to what or where it's going, and that's a problem. And we can actually feel some of these spots on the bones too through somebody's skin, and it's kind of helpful to be able to know that. Yes, Miss Walker T.
So this is a question that kind of combines this morning's lesson.
Oh yeah.
Hopefully it's still okay to ask it. When you were just showing lifting your arm in abduction and it only going up to shoulder height, so you were saying, well, then that means if you can't go past that, or maybe the scapula is not working. Could it also be that the supraspinatus is not working if it's not like unhinging that joint?
No. So I love the way you're thinking. But the supraspinatus had to unhinge the joint for me to get my arm up there.
Okay.
Right? So we know this occurred. That's how I got my arm up here. And there's no other way to get my arm up there. My scapula can kind of pull my arm up kind of like this, but I can't get it out to the side. That is really the glenohumeral joint, and that really is the supraspinatus. By the way, your thinking's right? You're very aware that the supraspinatus does an abduction and pulls it out here but that's what occurred. We know that happened. So the supraspinatus is probably not the problem. What you notice is, and you will see this, a lot of people pinch their supraspinatus. Don't worry, everybody, we'll go over all this stuff. And that's when you get the people that come in and they're kind of trying to compensate by moving their scapula more than would be normal because they don't want to bring this shoulder out because it pinches it. Because what happens is every time they bring their shoulder out, supraspinatus actually runs underneath. And every time they bring their shoulder up, they pinch it more in there. So it pinches itself. It's kind of nasty. And so that's the situation where we'd look at the supraspinatus, kind of the opposite.
Okay. Thank you for explaining that.
Thank you for thinking, using your brain. It's awesome. Okay, everybody. Let's look. See this wonderful mountain climber? Climbing up here. I'm not going to go over topographical anatomy because it's different on everybody. But later you should try to feel this stuff in your partners. Okay, so here we go. Bones of the shoulder and arm. Now, everybody, this is one of the tricky things about anatomy, is you are all three-dimensional people, but we are learning this from a two-dimensional book and two-dimensional slides. And so you need to start thinking three-dimensionally, which is easier said than done. So I'm also going to have the skeleton here if I can. We're going to try to, kill two birds with one stone here, see if we can't. There we go. See if we can't kind of, there. Okay. So you should have a slide of this and the skeleton here. Okay? And in a way, we're only going to be studying three bones here. The collarbone, which when I follow the collarbone over here, by the way, your collarbone is hooked to your sternum. Your collarbone is hooked to your sternum. Your collarbone is called your clavicle. This is your clavicle. So clavicle and sternum. So almost all joints are labeled like street intersections. When you guys come to school, you come to 29th Avenue and Bell. We all know what 29th Avenue and Bell is. If I said Bell and 29th Avenue, you'd still know. I can switch them. You know I mean where those two roads cross. This is the sternoclavicular joint. It's the sternum and the clavicle, sternoclavicular joint, all day long. Most joints work this way. Most joints are named by the two things coming together. You can feel your sternoclavicular joint. This is your jugular notch here. That bone right next, ow, that's my clavicle. And if I push right underneath it, that's my clavicle inserted into my sternum. If you raise your arm up and down, you can make your clavicle move a little bit. Anyway, that's your sternoclavicular joint. This is your clavicle. It's pretty easy to break a clavicle, not in massage, don't worry, although I wouldn't go hitting them. But if you hit them just right, usually at an angle right from here, about 5 pounds of pressure just right, and it's fast enough, they break. They're not that strong. This is the sternum, sternoclavicular joint, clavicle. If you follow the clavicle over, it meets the scapula. It meets the scapula at the acromion process. Yes, it meets the scapula at the acromion process, or I should say the acromion process meets the scapula. So what would the name of this joint be between my acromion process and clavicle? Acromion process and clavicle. Miss Estes, I feel like you're going to do it. I feel like
I'm
you're
gonna do it. The
Do
acromioclavicular.
Yeah, she's right. The acromioclavicular joint. Good. Boom. So that hooks to here. And then in back, they wired this scapula to this skeleton. You guys don't have wires. There is no bone connection in back. The scapula just sits here. Because there's no bone connection, this is not considered a joint. But that's just somebody's technical term. I consider it a joint. I most definitely consider it a joint. But, you know, people normally consider joints to have joint capsules and kind of hinges and things that we can identify. This thing's just floating around back here. Now, it's not floating willy-nilly. We just learned there's 5 muscles that control exactly where it's floating. In fact, if it was floating while you guys were typing or writing right now, you wouldn't be able to write. Your hand would be like, the first thing your hand does before you type is lock your scapula down to your back. It goes whoosh, because it wants the crane not moving around. You don't see cranes lifting girders up there and driving while they're doing it. They lock the crane down first. They put out the arms and they lock it down. So your body does the same thing. It's one of the reasons people's shoulders get tight when they type all day. Typing's not hard. Come on. Right? We've all done manual labor. That's hard. Why do my shoulders get so bad from doing this? Because my scapula's locked down for 8 hours straight. Yes?
It says, and you were saying like joints are named like intersections.
Yeah.
Where's the gleno part for the glenohumeral joint? Where's that?
Well, it still follows the rule, but it sure isn't friendly the way they did it. This is your scapula. A fossa is a depression. That's what fossa means. You've got them all over your body. We're going to learn 75 fossas. A fossa is a depression. This fossa is called the glenoid fossa. So this becomes the glenohumeral joint. I wish it was called the scapular humeral joint, but it's not. It's called the glenohumeral joint because the humerus, the head of the humerus, fits into the socket. It's not much of a socket. The glenoid fossa, glenohumeral joint. So that's why. Good question. So it follows the rule, but it's lame because you got to know this thing's the glenoid fossa. But it's very important to massage therapists, everybody, because we now know that there's 2 shoulder joints going on. We know this guy can be moving around. That is your scapulothoracic joint. This is the thoracic region. It moves around here. So I call it the scapulothoracic joint, and I'm not the only one, by the way. There's a lot of other anatomy people out there who are like, screw it, it's a joint. It's not a normal joint, but it's a joint because it does everything a joint does. We call this the scapulothoracic joint, and then the glenohumeral joint. And so what we were just talking about was when somebody comes in, figuring out if the problem is with their scapulothoracic joint or their glenohumeral joint. Which one's moving? Or are they both not moving? So these two work together. Now, you've got your clavicle, you've got your scapula, and you've got your humerus. That's the only three bones we're talking about here. So what joint attaches your entire shoulder girdle complex to your body? The humerus, the scapula, and the clavicle. What attaches it to your body? The only real joint is the sternoclavicular. There is no joint in back. Well, I just told you it takes 5 pounds of pressure to break this thing. So how come you guys are able to bench 200 pounds and lift luggage and throw books and massage each other when you've got such a weak joint here? Because the integrity of the entire shoulder girdle complex does not come from a joint. It comes from actually really the integrity in general of those 5 muscles I just talked about. Your trapezius and your rhomboids and your levator scapula and your pec minors and your serratus anterior are what control the scapula. And truly, and I'm not exaggerating on this, I tend to exaggerate on a lot of stuff, but truly, your scapulas hang off the back of your head and neck. They hang off the back of your head and neck. I don't mean they kind of hang. I mean they hang off the back of your head and neck. There's nothing holding them up otherwise. If I were to cut through your trapezius and stuff, there's lots of stuff on my body that if you cut through it, it would still stay there. Like there's a joint holding it in place and all these ligaments. This thing, if we cut through this stuff here, your whole entire arm would grossly be hanging off by a little clavicle down here. And you'd look like an egg with 2 little, it would be disgusting. Yeah. I mean, I wouldn't say that to you because you already have enough trauma to deal with right at that moment. I'd be like, it looks fine, we're going to fix it. But it'd be disgusting. So, when people have shoulder problems, they do have neck problems. When people have neck problems, they do have shoulder problems. And we used to think of your neck, its job was to hold up your head. No. This is the top of the tent pole. Your neck is there meant to be a tent pole to hang stuff off of. You're very much, in very many ways that we're going to learn about, hung like a suspension bridge, not just stacked up like bricks. You're much, much more complex. We used to think the body was just stacking bricks up on top, but we started to learn fascially that actually, no, you're suspended in this thing called tensegrity that we'll get to. And so your shoulders are actually hanging off the back of your head. And they're floating around until they get locked down by muscles there. That's how your scapulas move. Right? Okay. So, good. 3 bones. Clavicle, scapula, humerus. Yeah. Only bony connection to the body is sternoclavicular joint. And it's not that important of one. That thing just moves around all day long, depending on what I'm doing with my scapula. Right? It just kind of goes along for the ride. It gives a little bit of stability, don't get me wrong, but it's not major. Yeah. I love when I look out and see people doing stuff like this when I'm lecturing. I'm serious. This is exactly what you should be doing. What can you get to in here? Can you grab your collarbone? You can actually. You can get underneath it. It's good times. Yes, Miss Routson.
Sorry, I'm having charging issues, so I had to relocate. So I actually injured my shoulder waitressing. I was walking and I slipped on the floor and I did like a circumduction movement with my shoulder.
Thank you for putting those terms. Okay.
So I was just wondering, would that mean that I injured the glenohumeral joint? Or would that be like, the doctor could never figure it out, but whenever I do the circumduction, it clicks and pops.
Yeah. So, the clicking and popping is coming from your glenohumeral joint, almost for sure. Not 100% for sure, but most likely you're getting the clicking and popping from under here. And by the way, everybody, clicking and popping is not always a bad thing at all. If it does not hurt you, I wouldn't even worry about it. That's what most sports doctors say now. In fact, a little bit of clicking and plopping just means some play in there. It's kind of normal. But if it hurts you, Ms. Routson, that's a problem. Now, I don't know for sure where you injured it, but it is most likely you injured the glenohumeral joint. It's not a very strong joint. It's a highly mobile joint, and what you're describing are actions that bother it, right? Can you leave it alone and still elevate your shoulder and pull it back and do stuff like that without it bothering you?
I've done years of massaging it myself and like working it myself, but if I throw if I do a baseball bat move, I have thrown it out of socket.
Oh, I believe that. Well, I guess again, that's glenohumeral. I guess what I'm asking is, does it hurt you to elevate your scapula, to press your scapula, retract your scapula, protract? No. Because it's not a scapulothoracic problem. It's a glenohumeral problem. Yeah.
Okay.
Yeah.
Well, that makes me feel better. At least I know. Thank you.
Did they have you do rotator cuff exercises?
Yeah, at first I did some PT, but then I just kept doing PT for years because it just needed a little more attention, you know?
Yeah, more power to you. Good job. Okay.
I have a question.
Yes, Miss Estes, please.
Okay, so when you say injuring a joint, really you're injuring the little muscles or tissues within the joint, right? Like your rotator cuff. Is that what it is, or?
No, I mean, it could be. It's not, by the way, I'm not shaking my head at your question. I'm just thinking it's really complicated. So this joint, and pretty much all of your joints, the ones we're going to be dealing with, not the scapulothoracic, that's not really a joint, but it works like. But these joints right here, before we even have muscles on them, they have joint capsules over them. And the joint capsules are made out of fascia, of course, because everything's made out of fascia. And they're really strong. And there's even thick parts of the joint capsule that are really thick, and those are ligaments. And sometimes there's even ligaments running through the middle of it. And so you could, on a joint like this, you could remove all the muscles and everything, and the arm would still hang here because it's got all these ligaments and a joint capsule, and it would still move around. That stuff could be injured. So the ligaments, the joint capsules, the stuff that we call avascular material, and this is important. Avascular, A means without, so without blood. And of course it has blood, by the way. It's not a very correct term, but it has way less blood. Muscles are highly vascular. They get lots of blood into them. Tendons and ligaments and things like that don't get as much blood into them. There's the reason for that. It actually makes them stronger, but it makes them repair slower. So anyway, this stuff is highly avascular. So there could be a problem there. There could also be a problem literally inside the joint, right? We could have a little bit of the padding in here. The little bit of the cartilage could have gotten torn, and there could be floating around debris in there. All that kind of stuff. Those are fairly severe things, but the point is that could be going on. Then we've got muscles on top of that, and those muscles could be having problems. Sure. I'd actually prefer that. I prefer we just have muscular problems because we can probably fix those easier. They're going to heal faster. And by the way, we can have a combination, right, of all sorts of stuff. So that's what I meant. Yeah. There's just lots. There can be lots of stuff. Yeah.
Thank you.
But Ms. Routson's approach is a very intelligent one, which is let's build up the muscles to help protect the joint, yada, 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 and let's let it repair. Yeah. Okay. So, 3 bones, right? Ms. Trotter, what are the 3 bones we just discussed? What are their names?
The clavicle, humerus, and scapula.
Thank you, ma'am. Okay. So let's talk about the scapula. Here we go. The scapula. So, I hope what I'm about to tell you won't confuse you, but I think it's important to mention. If you think this picture is an anterior view of a scapula. However, you never see an anterior view of a scapula as a massage therapist. This is an anterior view of a scapula. You'd have to look through a rib cage and through all the pecs and stuff like that. You don't ever see it. What you guys are used to is posterior views of scapulas. Now, there is really important stuff happening on the anterior side we need to talk about. I just want to explain to you, this anterior side is also what you and I would call the underneath of the scapula, right? Some of you have already been playing with this in class where you lift up the scapula. I've seen some of you do it. It's awesome. You can lift it way up, by the way, because it's a free-floating joint. So in back, you can really lift it. But you are grabbing onto the anterior side of the scapula. You're reaching underneath it, and this is what we're looking at right now. So, remember how this thing's aligned on a back? Some stuff is kind of obvious once I've told you. This is close to the spine, and this is a border. This is far away from the spine, this is a border. How do we differentiate between these borders? What are we going to call the border close to the midline of the body?
Medial border?
Medial border, thank you. What are we going to call the border that's away from the midline of the body?
Lateral.
Lateral border, thank you. Medial border, lateral border. We'll use that kind of terminology for everything. So kind of get used to that. We have an angle down here, and we have an angle up here that very few massage therapists actually ever touch right here. But what should we call the angle on the bottom or below?
I think it's the apex.
The apex? Well, you could argue it's the apex, but what apex is it then? Because you've got two.
Oh, I'm lost.
And they refer, by the way, apex is not wrong. Some people do refer to it. But stick with the angle. But that's not the problem. The problem is there's two angles or two apexes.
Is that the inferior?
I'm sorry, what, Miss Walker?
I said his name. Mr. I can't tell who else is talking.
I can't
But
either.
yeah, I agree with her.
Inferior. Yes, which makes this one what?
Superior.
Superior. So we have a superior angle and inferior angle. A medial border, a lateral border. Some of that stuff I would hope right now, if I gave you a quiz right now and said, this is an angle, which one is it? That you'd be like, okay, I just remember that. Superior, sure, and inferior, and medial and lateral border. Cool. So, this is the picture they're showing you in the book right now. This is the anterior portion of the scapula. This is as though I was standing right here and you could look through my body and you'd see this guy. Right? But to us, this is the underneath part of the scapula. To us, this is the underneath part of the scapula. When you guys have been reaching on people's backs and lifting these things up, this is what you've been grabbing. You've probably been right about here. But you could get here. This is called the subscapular fossa. A fossa is any depression like this, and this is the depression underneath the scapula. Sorry, I have a tiny little mite flying around. Anyway, this is the depression underneath the scapula, and so it's called the subscapular fossa. Who cares? Here's why you might care. Later, when you learn this is the subscapular fossa, and you're learning your rotator cuff muscles, with which Miss Routson will tell you give integrity to her shoulder girdle joint, in the subscapular fossa, you will find the subscapularis. So it kind of matches the name. That's why it kind of matters. Up here, we have a little beak-like projection. You can actually feel it on your own body poking out right below the acromion process. It feels like a pencil right here, and it hurts. And some therapists accidentally rub over it thinking it's a knot, and it's not. That is the coracoid process. Coracoid actually means beak-like projection. Do you know what hooks on this guy? What hooks on the coracoid process? Anybody? Somebody.
Ribs?
Pectoralis minor.
Pectoralis minor. There's McDowell. Come on. Blood in, blood out. Come on. What happened? No. is right that guess where the pectoralis minor hooks? To the ribs. The pectoralis minor's job is to actually tie the scapula in front down to the ribs. And it's a super important job. There's a lot of stuff that just wouldn't be able to happen if this didn't happen. But it hooks to the coracoid process. Then we've got the glenoid cavity, which Ms. McDowell pointed out to us, interfaces with the humerus to make the glenohumeral joint, which is considered to be a ball and socket joint, by the way. Not a very good one, though. Mr. Tate. Yes, sir.
Yeah. So I missed the area where the scapula was connected to the pectoral minor. Yeah.
Coracoid process. It's this beak-like thing coming out the front. And believe it or not, it's where your scapula sticks through the front up here. Because you're an egg. And there really isn't a shoulder. I mean, this is just your shoulder, so this is your scapula sticking through, hooked down to the front of the egg. That's called your coracoid process. It's in the slide, too. But it's on this thing, too. I didn't know which was more helpful. This is really hard, via video. But you guys are doing good. Coracoid process. Then we got the glenoid cavity, which makes this ball and socket joint. Now, it's called a ball and socket because this is definitely a ball, and this is a socket and has lots of movement. But as Ms. Routson will tell you, it doesn't have much of a socket here. And so it's kind of easy to get it to do this. And that doesn't feel too good. So it's not that hard to pop a shoulder out of socket because unlike your hips are a ball and socket too. But they've got a socket to go in there. I mean, they've got a socket. They're in there. Like, it's big. It's around half the ball. There's no socket here, even though they call it a ball and socket. So actually, a lot of shoulder integrity comes from the muscles around it. We'll get that. But anyway, that's the glenoid fossa to make the glenohumeral joint. Cool? And then above it is the acromion process that we're later going to find out turns into the, not later, we're going to find out right now, it turns into the spine of the scapula. Spines aren't just your back. Spines are anything that stick out. We've got all sorts of spines on our body. And believe it or not, your traps like to hook onto this. They like to hook on the spine of the scapula in the acromion process. Your trapezius does. And that's why when people run up somebody's back, they feel this and they think they're at the top of the scapula, and they can never feel this because the traps are over the top of it. But guess what hooks on to the superior angle of the scapula? Levator scapula hooks into the side of your neck where all these nerve plexes come out. And so when it gets irritated, it messes with stuff. It's little, but it's a pain in the neck. Yeah. Cool. All right. There's two other things in this slide. They are tubercles. We're going to hear about tubercles all the time. Tubercles are bumps. Tuberosities are bumps. Trochanters are bumps. Bumps are bumps. They have all sorts of names for bumps in your body. But this is the tubercle above the glenoid fossa, and this is the tubercle below the glenoid fossa. What should we call the tubercle above the glenoid fossa? Please, Ms. McDowell.
Glenoid.
Tubercle.
Tubercle.
Thank you. And what should we call the tubercle below the glenoid fossa?
Infraglenoid tubercle.
Infraglenoid tubercle, thank you. Thank you. Mr. Tate, by the way, did you still have your hand up just by accident, or do you have another question, sir? No.
It was by accident.
Cool. I just don't want to ignore you guys. I know sometimes I don't see your hands. So, why would I care about these two stupid little bumps inside this stupid little socket?
Mr. Ybarra was saying that the bumps aren't there for accidental reasons. They're there because muscles attached to them.
Yeah. So we will study this at length. Right now we're just doing bones, but I'm just trying to get you guys kind of excited and remind you why it might be important. Remember my biceps here? Biceps means two heads, bi. One of the heads goes up my arm, through this little groove here and attaches into the supraglenoid tubercle. So that means in this joint that I've already got the supraspinatus muscle going through up here, people are already getting clicking, I've got a bicipital tendon up here too, hooked in here. So that's significant because bicipital problems in your biceps could be affecting your shoulder. But you'll know that because you studied anatomy. So when somebody comes to you with shoulder problems, you'll be looking at their biceps too, and they'll be like, that really seems to help. I can't figure out why, because it's my bicep. I do curls with that all day long. And you'll be like, well, yes, sir, of course you do curls with that all day long. That's the main job of your bicep. However, a lot of people don't realize that it inserts into the supraglenoid tubercle, which is actually inside your shoulder joint and actually aids in a shoulder flexion, which is why you're having some problems with your shoulder flexion too. And they'll be like, oh my gosh, you're brilliant. I should pay you double. And then the infraglenoid tubercle, believe it or not, one of the long head actually, one of the heads of your triceps from the back of your arm inserts here. People don't think about it. They think of their triceps all day long as doing extensions. And that's what their main job is. But my tricep actually hooks to my scapula, and one of the heads can actually help with an extension of my actually entire arm. So we will get back to that. I just want to point out these bumps are important. All right. The medial border is important because you will grab it to lift up a scapula. The lateral border is important because you're going to find later that the lats run along it and the teres major and all sorts of stuff. The subscapular fossa is important because one of the rotator cuff muscles, the subscapularis, attaches there. The spine of the scapula is important in the acromion process because the trapezius attaches there. The coracoid process is important because 3 muscles attach to it. Pec minor and 2 others. And so they're all important. So let's look at the other side of this beautiful, incredible bone. This is the side you're used to seeing or feeling. Obviously, you're not used to seeing it. But this is the side that we approach when we touch on somebody's back. So this is actually a posterior view, but to us, it's what we're used to. This is what you're used to feeling, right? So we can still see the medial border, right? But we've got these fossas that are above and below the spine and the scapula. What should I call a fossa that's above the spine of the scapula? I think it's in the slide.
Supra.
Yeah, supraspinous fossa. It is the fossa above the spine of the scapula. Supraspinous fossa. Hey, what muscle do you suppose probably has an origin in the supraspinous fossa? Anybody?
The supraspinous?
Supraspinatus. Yep.
Spinatus, yeah.
Supraspinatus muscle lives in the supraspinous fossa. I know this seems a little overwhelming right now, but actually later it's not going to be overwhelming at all. What do you call the fossa underneath the spine of the scapula?
Inferior?
Pretty darn close. It means inferior infraspinous fossa, which means inferior spinous fossa, infraspinous fossa. And there's a muscle that lives down here called the infraspinatus. It's in the infraspinous fossa. So that stuff's important. Cool, cool, cool. All right. That's the scapula. Here is the humerus. This gets a little trickier, but it's super important too. So we've got this round thing at the top, and it really is round. Yeah? And it's called the head of the humerus. It looks like a head. It's called the head of the humerus. And then we've got a big bump and a littler bump. Bumps are called tubercles. So we've got a greater tubercle and a lesser tubercle. Later we will find out things like, well, a lot of the rotator cuff muscles grab onto the greater tubercle. We actually even have a groove between the two tubercles. So does anybody know what interstate transport is? Interstate transport. It's transport between states because inter actually means between. To me it almost sounds like enter, but no. Inter means between, and we use it a lot in anatomy. So interturbicular groove is the groove between the tubercles. Interturbicular groove is the groove between the tubercles. And the largest muscle in your upper body actually inserts into the interturbicular groove, the latissimus dorsi. It needs a large area to grab onto and really have force to pull. It's quite impressive. That's the latissimus dorsi. Hooks in the interturbicular groove.
Mr. Chestnut,
Please, Miss Walker.
and that groove is facing medial?
That groove is facing.
Can we feel it?
Yes, you can feel it on somebody. It's actually, by the way, so it's called a couple things. It's not real pleasant. Be a little careful digging around. Not because you'll break somebody, but just because you'll irritate them. It's facing anterior and middle, kind of a little bit, depends on how their arm is located. And it's also called the bicipital groove because the long head of the bicep that's going up to the supraglenoid tubercle, the tendon actually runs through here. So it's called the interturbicular groove or the bicipital groove. And sometimes people's bicipital tendons get knocked out of it and they have to pop it back in. So anyway, yes, you can feel it though. The short answer is yes, it can be felt if you go digging around. It's way up there, but yes, absolutely. Yes, Ms. McDowell.
Probably dumb question, but
Probably
do
not.
we have to know all of the bony landmarks? Is it all of them? Like on the muscle, the bones you're showing us, is it all of them we need to like super know?
Yes. I was trying to think. I was like, because I don't like to tell you have to know stuff you don't have to know. Like, I really pride myself in the fact that, like, we teach you really, really well, but we try not to waste your time. I admit that so here's what I was hesitating on. Let me explain something to all of you. They name some things that I've learned and then forgotten because I don't have to remember the whole thing. Let me give you an example. They name these darn condyles. They name these darn condyles by, I don't know if it's going to be dark enough. Let's see. So let's say you've got a bone here. You've got sometimes these condyles on the end. Now, this is a condyle and that's a condyle, and condyles really are for connecting muscle to. They're there for a reason. But they get real nitpicky with pieces of the condyle, and they're kind of named like mountains, and we really do think of them like mountains. So they tend to not really look like this. They tend to kind of look like this and kind of swoop down, like just like a mountain would. And so we call this spot the epicondyle, like the epicenter, like the dead-on condyle, right? And then this whole thing is like just the condyle, and this is the ridge of the condyle. And we're really just describing a mountain. Now, do I think that your life will be forever changed if you can't quite identify between those? And no, I totally admit that. I don't distinguish between condyles and epicondyles. To me, it's ridiculous. There's a bump there, and basically stuff is attached to it. Ridges and condyles I do kind of, because some muscles like to grab onto the ridge, and some muscles like to grab on the condyle. So to answer your question more precisely, in your open book test, obviously you got to get the supracondyle not mixed up with the condyle, all that kind of stuff. But in the real world, we just want you to understand there's bumps, and they have slopes coming down them. Those bumps are condyles. There's a slope coming down them, or there's a greater tubercle and a lesser tubercle and a groove between it. We care about the kind of big stuff, not this nitpicky last little stuff. But in this picture, most of it's not nitpicky. So let me give you some examples. Like the greater tubercle, 3 of your 4 rotator cuff muscles attached to it. The intertrabecular groove, your latissimus dorsi attaches to it. The head of the humerus makes your glenohumeral joint. The lesser tubercle, I got to remember now, lesser tubercle, your last rotator cuff muscle attaches to. The rest of the lesser tubercle, I'm guessing at this point because I've actually forgotten, but I think your teres major attaches to. The deltoid tuberosity, all your deltoids attach to, right? The capitulum down there sounds crazy, but the capitulum is actually what my radius rotates back and forth around so I can do this. It's kind of important. The radial fossa literally makes space for my radius to go like this. I wouldn't be able to bend my arm all the way back, actually. I'd stop like there if I didn't have the radial fossa. The coronoid fossa is kind of the same, and the trochlea is part of how my elbow really functions. I will say that all this lateral epicondyle, lateral condylar ridge gets a little annoying. I want you to know that there's medial and lateral condyles. Yeah, so that's the one part that's a little bit extraneous. Do it on your test, and it's not like I'm going to ask you to distinguish between those again. I hope that helped. Cool. All right. Cool. So this is the back side of your arm. And you can see the greater tubercle there. And you can see something called the olecranon fossa. Can everybody see the olecranon fossa down at the bottom? A fossa is a depression. Here's our beautiful little skeleton. The olecranon fossa is right here. It's a depression here. If it wasn't here, you would never be able to bring your arm straight all the way. It actually makes room for your ulna to fit into your elbow so that you can straighten your arm out all the way, which is kind of helpful, so you can lock your elbow. Otherwise, you'd stop right about here. You bring your arm out to here, you'd never be able to quite straighten it. I can straighten it because I've got a hole in that bone that allows the bone to go back even further. That's what the olecranon process is for. Fossa is for. The olecranon fossa is to hold the olecranon process, which is my elbow. We don't call this an elbow. We call it an olecranon process. Or a cubital. Yes. Is that Miss Routson?
Okay, so I have to ask what this little protrusion is that's called my funny bone that really isn't so funny when I hit it.
Yeah. So, you have some nerves. Let me just make sure I'm telling you right. It is actually in this picture. The groove for the ulnar nerve is right here. And that's the one you hit sometimes, and it really hurts because the nerve is exposed. If there's no muscle over it right there, as it comes around here and goes right through here and goes up, and that's when you're hitting your funny bone, your humerus, and you're hitting your ulnar nerve right there, and that's what you're feeling most likely. There are other nerves there, by the way, but I'm guessing that's the one that you're experiencing. Yes, Miss McDowell.
Kind of to play devil's advocate a little bit, I've heard that that's actually, it doesn't hurt, it just kind of like sends weird signals because you're not supposed to hit it, so it doesn't know that it's actually painful. It's just a weird, like, TV static sensation when you hit that weird area.
I'm getting tired of this, but I 100% agree with you. I 100% agree with you. You're right, it's not painful. It is a zinging thing that your brain cannot interpret, and you're getting signals there, and it's like, this is weird. And you got to understand that when you hit a nerve here, to your brain, it's kind of like, well, did the nerve get fired down here? You just hit the telephone wire on its way to wherever it was going. And so you get this staticky kind of thing, and we're not used to it, and it's very unpleasant because it's weird. But yes, you're right. It's an interpretation thing. I don't know that you're not playing devil's advocate. You're being smart. And it.
I can stop if you want.
No, it's good. It's humbling. I appreciate it. It's fine. No, it's great. It's fantastic. Anyway, no, you're right. But anyway, that's the nerve though. And you're absolutely right, you're getting static. You're getting static. This is why I ask clients too when they say something hurts, I'm like, is it a good hurt or a bad hurt? Because sometimes they're literally like, oh, well, actually it's kind of a good hurt. Keep doing it. Because they haven't even thought about it. It's just a sensation to them, right? You know? It's all how you interpret it. Some of us think spicy food is a painful experience. Others think it's wonderful. Yes, Miss Walker T.
Hey, the pictures that we have, where it has the front of the arm, that would be us in prone, or whatever that position is.
That would be you supine on your spine in anatomical position, yes.
It would be in it. So so in this picture,
This is this picture.
it's a little bit rotated.
Well, this picture is somebody perfectly in anatomical position. They're like this. They're not letting it drop in at all. They're in anatomical position. Actually, I'm so sorry. This is posterior view. They're in anatomical position posteriorly right now. I lied.
Yeah, I'm trying to feel the bumps on the.
Good. You guys should be able to, by the way, feel your medial and lateral epicondyles right here. Those should be sticking out at you, like on all of you. This is your medial and lateral epicondyle. You should be able to grab them right now. All of you. This should not be hard to find. Your elbow is actually not part of your humerus, it's part of your ulna. It fits into your humerus, but these are the obvious things to find, medial and lateral epicondyles. And strangely enough, we care about those later when we study forearms, because a lot of your forearm muscles actually attach to your medial and lateral epicondyles. And the trochlea, by the way, I'm sorry, I didn't explain the trochlea. The trochlea is a very fancy part of your elbow joint that just makes for a very strong elbow joint. So your ulna hooks into it and slides around it very well. And that's just this nice little kind of pitted thing that the ulna sits in. It's called the trochlea. And that, by the way, Miss McDowell, is something that I would be like, okay, now that you've learned the trochlea and that the ulna goes into it, a year from now you might forget it's called trochlea and it won't ever matter. But you do want to forever remember that the ulna fits into this little groove there, that kind of stuff. So some of this you'll lose later, but yeah. But most of the bumps are important. 95% of them. Yeah. Okay. What's not important is clavicles are important, but the fact that they want to name all the stuff around the clavicle. So it has some little lines on it and things like that, that certain ligaments and things like that. Just remember it's a clavicle. Now, some stuff should be obvious to you. It has two ends, and they call the end by the sternum the sternal end. It has an end by the acromion process, and they call that the acromial end. And it has a front and back, and they call it anterior and posterior, but that's it. That's it. You don't have to get all the little nitpicky stuff there. Yeah. And that